just by having a 2 millimeter restoration, the tooth is now bending and flexing much different than the natural tooth. Biomimetic dentistry tries to mimic the natural tooth. That is the ultimate guide in how we restore a restoration.
Hello and welcome back to the Noobie Dentist podcast. I'm your host, Dr. Omid Izami. This is another episode of the Noobie and Friends series where I catch up with old friends and friends of the podcast to get a review and an update on where they are in their careers, and also to catch me up and get me reacclimated to general dentistry after spending a year or so away. In this episode, I catch up with friend of the podcast and the most popular guest that I've had on the show. He currently holds 3 of the top 10 episodes downloaded this podcast, and that is Dr. Davey Alleman. Dr. Davey is a big dentist in the sphere of biomimetic dentistry and is doing an amazing job teaching, educating, and bringing information to dentists from around the world with regards to biomimetic dentistry. And in this episode, I was really excited to get a chance to catch up with my old friend to talk about where he is with his current career working in private practice with his father, and also the education program that they're running, the modular-based biomimetic course that they're running, which I will link to in the show notes. In this episode, we do a bit of a review of biomimetic dentistry, and I had the opportunity to ask Davey all the pressing questions I had when it comes to restorative dentistry. If there's been any updates, if there's any new or better or more modern techniques that I have not heard of or have missed out on over the last year or so. And we also talk about the management of the elusive cracked teeth, how to diagnose it, how to assess it, how to manage it. And I think that you guys will get a ton of value from that discussion, because it is certainly an area in dentistry where I think a lot of us are wondering what the best management option is. Do we chase the crack? Do we ignore the crack? Do we preemptively discuss this with our patients and jump in and treat, even though there may not be any symptoms associated with the cracks that we're seeing on our routine exams and recalls? This week's episode of the Mini Implant Audio Residency is brought to you by my good friends at Mordent. Mordent is your proudly Australian-owned and operated partner, driving the charge forward in integrated digital dentistry. Being the only fully integrated local dental company, Mordent offers world-class education, equipment, products, solution, and support. The Mordent team of over 50 specialists are helping thousands of Australian practices to seize the opportunities in digital dentistry, transforming treatment for their dentists and the patients alike. Whether you're seeking to upskill through education or are considering implementation of digital dentistry into your practice, or just looking for some advice, I highly recommend reaching out to the Mordent team. Visit www.mordent.com.au to find out more. I will include their information in the show notes for those interested. As always, if you're new to the Noobie Dentist podcast, thank you for checking us out. Be sure to head back and check out the previous episodes that I've done on the podcast. I've had the privilege of having some amazing guests on the podcast over the past couple of years. If you're returning, thank you for your ongoing support of the Noobie Dentist podcast. I hope this podcast is full of value for you. And if you are getting value, please head over to iTunes and give the show a 5-star rating. These ratings help the show get more traction within the dental community. Without further delay, enjoy this week's episode. I am here with a podcast favorite. Actually, I was looking back at the podcast data, Davey, and you hold, I think, 3 of the top 10 positions. So I think single-handedly you've kept the podcast afloat and running. So I do have to thank you. Thanks again for coming on today to join this Noobie and Friends series to do a bit of a review on biomimetic dentistry. And we'll spend some time talking about cracked teeth as well, which seems to be a big problem going around that I think a lot of dentists struggle with how to manage it. So I know this is an area that you spend a lot of time, in clinical practice working on, and also teaching through the biomimetic courses and modules that you run. And we'll talk about that on the podcast as well. And maybe we'll see if you're actually starting enrollments for the following year so people can follow a link to that or something as well. That'd be great. So before we start, I know if people haven't heard the previous episodes, maybe just tell us a little bit about yourself and sort of what you're up to in your career, and we'll take it from there.
Okay, I'm Davey Alleman. I graduated in the first class from Roseman University of Health Sciences. Was enrolled from 2011 to 2015. After graduating, I joined the military, or I guess I signed my commission even before I started dental school. They paid for my tuition, but they got to tell me where I lived, how many push-ups I had to do each day for 4 years. So I spent my first 2 years out of dental school in South Korea. Wow. It was a great experience. Learned a lot as a clinician and also as a soldier. And when I say soldier, I use that term pretty lightly, because if you saw my frame, I'm like 145 pounds soaking wet. A strong wind will knock me over. After those 2 years in Korea and really trying to push myself to become a better dentist, I mean, one thing that many young dentists, they feel discouraged because they see really good dentistry done either on social media or maybe a partner that they're working with or a boss that they're working with, and they just don't know how they're going to get there. And you have to remind yourself that doing dentistry is like any other skill, whether it be learning the piano or improving at golf or running a race. It takes time. You don't become great overnight. And it was no different for myself. And it was frustrating because I come from, a heritage of key opinion leader dentists, or whatever that means.
Yeah.
But, year one was a difficult, challenging year. I was getting bombarded from leadership in the military saying, look, you shouldn't do it this way. You should place amalgams. You should place crowns. You should focus on extractions. And that was something that never got me excited about dentistry. I wanted to be a biomimetic dentist since I was in 7th grade when my dad lectured to my careers class, and he was excited about dentistry.
Yeah.
And then all of a sudden, I'm no longer going to become a pro golfer. I'm going to become a professional dentist.
That's pretty incredible. There's not many people that were in 7th grade wanting to be biomimetic dentists, so I think that's pretty unique there.
Yeah. So after year one, year two was a lot better. I got less pushback from my boss. I was able to really start incorporating a lot of the dentistry that I was trying to do in dental school, taking a lot of heat from faculty instructors. And over time, they just realized fighting with Davey is just not worth it. The guy just won't die. So 2 years in South Korea, last 2 years in the military was at Fort Huachuca in Southern Arizona. And, there I became, I don't know. That's when we first started interacting. It was in Arizona. So
yeah, it was probably like maybe late 2017, early 2018. I think that was like sort of when we first had our first intro to Biomimetic Dentistry podcast.
And then after my 4 years in the military, I've been in private practice for about 2 years, working with my father and also with another doctor that he trained over a decade ago.
That's awesome. And tell us a little bit about the courses, the biomimetic courses that you guys are running as well. I know you mentioned in the pre-interview chat that it's sort of growing quite nicely and you're helping a lot of dentists from sort of all over the world. What's it like for next year? I know if people are interested in learning these modular-based, curriculum-based courses, which are really nice and structured. Are you still accepting enrollments for next year, or is that full already as well?
Yeah, we're still accepting enrollments. We'll start the January module sometime in January. Mm-hmm. When this is being recorded, we are literally like 3 days away from starting the September and final mastership for 2021. Now, when I got out of the military, I had no dreams of teaching. I just wanted to fix teeth. Mm-hmm. I just wanted to fix teeth the best I could. I wanted to get better the following day than I was the previous day. Now, when I got out of the military, there were some shifts, and my sister, who was really the brainchild with this idea of going on to an online format. This was pre-COVID. And so she's explaining to my dad, who at the time is 68, 69 years old, that you're no longer going to be getting on planes and you're going to be lecturing to live audiences, but you're going to be lecturing from a computer. Mm-hmm. and she's asking me if I can, update some of the presentations. And I'm just thinking, I just turn into my dad. I'm like, what's Zoom? Now, I think our first interview was
on Zoom. Yeah.
And I had a hard time like downloading the software, and you're like,
Yeah.
where are you? And now it's something that I'm using every week,
it's
or
crazy.
like every day, like, interacting with doctors like you in Australia. Before I had this call, I did 2 mentoring one-on-one calls with the doctor in Ireland and another one from Scotland.
Nice.
And it's just really interesting how a technology that was so foreign 3 years ago when I first met you, Omid, is now
every day.
I don't want to say it's my life, but
what I'm upset about is, I think I would be a pretty big early adopter in Zoom, just using it. Cause I remember when I started launching the podcast back in like 2017, I was trying to find what software to use to kind of connect with people. And like, I was looking at Skype and like Microsoft Teams and all this stuff. So I'm upset because I've started using Zoom, and it's such a great, amazing product. And I could have had like a massive early head start if I actually had invested in Zoom. And now it's like, once COVID came, like the Zoom stock prices like shot up. I was like, oh man, I missed out. I should have been using it. Should have invested early.
But anyway, it was really good. So we did our very first mastership course before the world shut down and lost its mind.
Yeah.
And so we really didn't know how well it would be received for, doctors. The only benefit that we could really see is that no one had to travel to Utah to hear like a 3-day lecture given by my dad.
Yeah.
Now, when we started doing it over a longer period of time, we found that over a 2-month span to learn a large amount of information was actually better, because they could just focus on one aspect of restoring a tooth biomimetically. In other words, we are not cutting teeth down for mechanical retention, and we're not doing preemptive endo on teeth that are testing vital. And so like the first week or the second week, you're just focusing on caries. And every dentist feels like they're really good at treating decay until the first time that they put caries detecting dye and they realize where they're routinely leaving a large amount of decay, and in critical areas where the pulp doesn't reside. And so as we were seeing the doctors just progress each week, that first mastership in 2019, it was really, really eye-opening, because when we saw each other in DIA, we actually hadn't launched it.
Not yet. You're talking about it. Yeah.
We already had like a full class in January, but we were talking about the following one in March that year. And then, so we did the 2 months. It was really, really good. The doctors really embraced the material, and we saw that they learned it at a better rate than doctors that were just being trained over a weekend. And that's just because the human brain can only remember about 30% of what it takes. It doesn't matter how good I teach material, the human brain can only retain 30% of what it listened to.
Yeah.
You have to have repetition, and you have to have enough time to process a new material. Mm-hmm. If you're learning a trick on a skateboard, you have to have a previous trick in your muscle memory before you can move on to the next progression. If you jump to something too soon, it doesn't matter how much you practice it, you literally don't have the neural connections to move to the next step. And so by elongating the training to a 2-month program and then a year-long mentoring, we found that the doctors, even though we're kind of pulling back the reins in terms of how fast they're getting material and how fast they're learning a technique, it's like once the technique is presented, they're ready for it. And by doing that, all of a sudden the consistency among the doctors we trained improved dramatically.
Yeah, that's awesome. And I think I'm a big advocate of, whether in biomimetics or any sort of other aspect of dentistry, like signing up for these sort of like curriculum-based, long span, modular things are much better, because one, like you said, you have the opportunity to learn something and apply it in practice, and then like a month later review it and learn something and try it again. So you're not like kind of getting dumped all this information and you kind of have to try and work through it yourself. And then also like the accountability of like the monthly meetups, it keeps you sort of in the loop and in that mindset of like learning and going through something and understanding it. So I think it's a great way of learning. I think it's definitely a good approach to have it over Zoom as well, because it's a shame for people outside of the US to like miss out on such great content. You know, I know you got a lot of people from the UK and Europe, and I know there's a few Australians as well that do the course with you guys. So it's nice that they all have access.
And one thing that's so great is a doctor can literally not have to be there presently. Mm-hmm. It's better if they're there live, but I can't tell you how many doctors we're just watching the recordings. Our first, we had no idea when to put the time slot. We had 10 doctors all the way from Hong Kong to England, and then a couple in the US. Yeah. And so my sister's like trying to figure out a time slot that would work for everybody. And the answer was, you can't pick one that works for everybody. So she picks like 2:30 our time, mm-hmm. which is in the middle of the workday for US doctors. It's like for the European doctors. And then we had this doctor in Hong Kong, and it was 5:30 a.m. So it's like, if he really wanted to, he could wake up.
Yeah.
But I can promise you, if there was something at 5:30, I wouldn't wake up.
Yeah.
So we really didn't know how well it was going to be for him, because he was just going to get the recordings the following day. And it may not have been the easiest way to learn it, but I have interactions with this doctor, pretty routinely, and he's doing very, very good in Hong Kong. But, the flexibility that Zoom provides, where you don't have to get on a plane and be jet lagged to learn about,
and the cost and everything, like, it's just incredible. Yeah.
I mean, for you to fly out to Seattle to do a couple of days with Dr. Kois, I mean, the travel alone just adds another
hotel, time off work. Like, it's just like, it's a huge double cost essentially, because you're missing out on income as well.
Yeah, the double cost is really what gets you. It's the time out of the office, along with the travel, and then you have to top that off with the jet lag that you're recovering from. So, for the international doctors, this is a game changer.
Yeah. And
for the domestic doctors, they can come see us anytime. But one thing that we didn't know is you really get to know a lot of the participants better in this format, because you actually see their screen, you see their name, and each week you're talking about, hey, how are you doing? So and so, like, how are things in X part of the country? Mm-hmm. And all of a sudden, everybody in the group starts becoming well acquainted with everybody, because
quite nice.
They see each other on a front row basis instead of like in a big
auditorium to everyone. Yeah, no, it's pretty. It's a great medium for sure. So if you after we're done, if you can send me a link to the website and the platform and information about next year's, I'll put it in the show notes for anyone interested, and they can kind of check it out and have a think about signing up. I definitely encourage people to do so. So let's shift over to biomimetics a little bit. Last time we chatted was a couple of years ago, so I'm sure there's been some innovations or changes. Last time we talked about, obviously like the biobase and making sure your DEJ is clear and, a couple of millimeters around that peripheral seal zone, and the hierarchy of bondability and letting bonds mature and things like that. So I got some keywords in there, but why don't we, I guess, like, let's, in terms of how are we going to phrase this is, let's say you're working on a lower 6, there's an MOD on it, amalgam MOD, because I'll just a case from yesterday I saw. So let's do upper left first molar. There's a large existing sort of MOD amalgam. Patient comes in and they fractured off like the mesiopalatal cusp or mesiobuccal cusp. Talk to me through how you assess the tooth, how you decide direct, indirect, how do you decide how you're going to restore it, through the lens of the biomimetic side of things.
So when I see a tooth that has had like a fracture of a cusp, we call this a clinical failure. The patient is aware that there is a problem, and they're seeking your expertise, whether you're practicing in Brazil, the US, Canada, Africa, Asia, Australia. They want a dentist that's proficient in fixing their tooth. Mm-hmm. Now, the real question is, how did that tooth fracture? Yeah. And that tooth didn't just fracture overnight because all of a sudden they had additional stresses from, lockdowns and COVID and uncertainties. Now that definitely attributes it. Mm-hmm. But I'm going to go as far as saying that crack was beginning to be initiated, or it had moved past the DEJ 3, 4, 5 years prior. Now, in lesson 2, we talk about structural analysis, where we're analyzing the integrity of the tooth. A tooth that has not been non-restored will fracture at roughly 550 pounds of total force. I don't know what that's in kilograms. I'm sorry.
That's right.
Americans.
I don't know. Measurements. Divided by 2.2, I think, or something. Or
but based off of an article written in 1981, which was before I was born, it was before you were born, it showed that if you did an MOD or even an occlusal restoration that was 1.5 millimeters, it lost 40% of the fracture resistance. So instead of 500 pounds for it to ultimately fracture, it took 300 pounds. Now, if you extended that a 0.5 millimeter, which is the thickness of your fingernail, you lost an additional 20%. So you went from 500 to 300, now to 200 for a relatively conservative restoration.
Yeah.
An MOD that's 2 millimeters. If you did that in dental school, you'd be like, where am I going to put the filling?
Yeah.
And your grader's like, is this parallel enough? Is this, how good are your hands? You seem really, really shaky.
Yeah. This is not for you. Yeah.
But anyway, it's like, just by having a 2 millimeter restoration, the tooth is now bending and flexing much different than the natural tooth. Biomimetic dentistry tries to mimic the natural tooth. Yeah. That is the ultimate guide in how we restore a restoration. Now, what gives a natural tooth the ability to withstand fracture? Well, a researcher named Tim Rainey in Refugio, Texas, along with Graham Milicic in New Zealand, they really studied the nature and the substructure underneath the occlusal enamel. And they found that there are these webs of enamel that connect cusp to cusp on both mandibular molars and maxillary molars. And these subocclusal transverse ridges reinforce and buttress the tooth so it's able to withstand multi-directional loads. Mm-hmm. Now, as soon as you cut into these subocclusal transverse ridges, or you can call them Rainey webs or Rainey ridges for short, since Tim Rainey was the first person to discover this web of enamel that is connecting just above the DEJ. If you cut into this, it's the first step to weakening the tooth. Just like if you open up a can of Coke, a can of Pepsi, mm-hmm. all of a sudden it's much easier to have a permanent deformation of the can than if the can is intact.
Yeah.
So a lot of people have heard the idea of a compression dome. That's, the same concept. You want to, regain the connection side to side, top to bottom. And if you're putting everything under compression, then the tooth is bending and flexing in more compressive rather than tensile loads. So once you've cut a conservative class 1 that has removed the subocclusal transverse ridges, you need to think that these teeth are moving. Teeth aren't static.
Yeah.
So a virgin tooth, when it's being chewed upon, it moves 3 microns. That was shown by Monye and Ogunasiyan in 2012. Now, if you do slot preps, the tooth still moves at roughly around 5 microns. So it still has those subocclusal transverse ridges. The tooth still has its structural integrity. It's not at risk of fracture. But now, as soon as you go into the occlusal portion, all of a sudden the micro movements change completely, especially with an unbonded restoration. And it goes from 3 microns to, when you do an MOD, to 175 microns. 170 microns over time fatigues the material, it fatigues the tooth and allows a crack to initiate and propagate over time. It may not lead to a clinical or a catastrophic failure where part of the tooth or a large portion of the tooth has been lost, but just like a crack in a windshield doesn't just start across the entire span, it starts as a rock chip. And so the earlier you can intervene in a crack, the sooner you can regain that connectivity. Mm-hmm. Because if you have a perfectly bonded restoration, that MOD that was moving 175 microns can now move at 7.58 microns. So it's not bioreplication, but it's biomimetic. It's mimicking. Yeah, it's closer to that 3 microns than 175, which is a world apart.
Mm-hmm. That's crazy. So in a non-catastrophic situation, and we'll get to it. So let's finish off this train of thought then. So with this tooth, then, so now you've assessed it. You've looked at the options. The tooth is, the margins are sort of super gingival. What's left of the fracture component of it. You take out the existing amalgam, and so how do you? Let's talk through the restorative side of it.
So as soon as we diagnose the tooth has lost its structural integrity or it's structurally compromised, we base that off of measurements. The first measurement would be the isthmus width. An isthmus that is greater than 2 millimeters, you can relate it back to the Larson article. It's lost 60% of its fracture resistance. Mm-hmm. So this isn't going to be just a simple filling. This is going to be more time consuming in order for us to regain the connection. Yeah. And the second measurement for a horizontal compromise is a cusp thickness. A thin cusp will act more like a dehydrated portion of the tooth and will be less resistant to fracture. And as soon as the cusp is less than 3 millimeters, as the dentin becomes more dehydrated, or that thickness becomes less and less, then that 175 microns becomes very significant, because it only takes 6% of the cuspal thickness for a crack to initiate. That was shown by Kishin and Van Dotten. And so if you have a 4 millimeter cusp, it takes 240 microns, so to get a crack to initiate. So 175 microns is still it's not going to crack. Yeah. Now, as soon as you get to 2 millimeters or even 3 millimeters, then you're right around that 175 microns movements, and that at any time or any kind of chew, you might be able to get enough movement that all of a sudden the tooth doesn't come back to its original shape. It's past its elastic limit.
Okay. Oh, interesting.
So as soon as you have a diagnosis of structural compromise, you should be thinking more in the terms of an indirect approach rather than a simple 20-minute filling. Now, in biomimetic dentistry, you'll never do a 20-minute filling, but that's kind of my criteria. If there's a wide isthmus, if there's a thin cusp, then I'm looking more towards indirect partial coverage.
Yeah. Okay. So and I've noticed a lot of these ones. So I'm sure everyone kind of listening would have seen some of these. So before you restore it, whether you're going to go ahead and prep it for an onlay or build up a core to come and restore later on. So you'll remove the existing amalgam there, and you'll even the one I saw yesterday when I was talking to you, I was at work. The other cusp, the remaining cusp had you can see sort of running from the marginal ridge, like the floor of the prep across, there's a crack underneath the cusp that you can see sort of within the tooth itself. So you can see that cusp is going to go pretty soon as well by the looks of that. But I want to get to cracks as a separate thing. So let's talk about the restorative side. So let's say this tooth was indicated for direct restoration. Talk me through sort of, you got your LAs on, rubber dams on. Let's talk to the actual restorative protocol that you're following now. And one thing, if you can touch on, and I have no idea what it is, and it's those little ribbons that I've seen people on Instagram and stuff putting on their teeth. So if you can include that in your restorative plan and why, that'd be cool too.
Okay. So the first thing that I want to do is I want to establish a caries-free and a crack-free peripheral seal zone. The peripheral seal zone is the 2 millimeters inside the DEJ. This is an area that is well away from the pulp. You can be very aggressive in removing tooth structure without running the risk of having a bleed from nicking the nerve.
Yeah.
Once I have that peripheral seal zone clean, then I can start having a foundation and have a compressive restoration that supports anything that's inside that may be closer to the nerve that I wasn't able to completely excavate. So we have a clean peripheral seal zone, and we'll also have a crack-free peripheral seal zone where we're removing all of the cracks and all the decay in this area.
Yeah.
And we know what our bond strength is because by using caries detecting dye, we can visualize the hierarchy of bondability. Now, inside the peripheral seal zone, we now name that the central stop zone. This is 3 millimeters from an adjacent marginal ridge and 5 millimeters occlusally. So if you're in those measurements, you should just stop drilling, stop what you're doing, and then you're going to take a different approach to either protect the weaker bonds that you are trying to maintain the seal, or bridge or redirect forces on some cracks that you weren't able to completely excavate. Because there's no such thing as like ideal dentistry typically when a patient hasn't been coming in and you weren't able to diagnose something early.
Yeah.
So once I have a clean peripheral seal zone, a crack-free peripheral seal zone, and my central stop zone is as clean as it's going to be based off of the measurements of 3 and 5, then I will Aerobraid the tooth. This will help compact and minimize the smear layer and make my Selfetch adhesive much more conducive and increase the bond strength in the range of what the tensile strength of the DEJ, right around 51 megapascals. So I'll prime for 20 to 30 seconds, air dry the tooth, remove the solvent, and then place the adhesive, which is a more hydrophobic layer that interacts very well with the difunctional monomer of the priming step, and then light cure. As soon as I've cured my adhesive, that's when the clock starts.
Yeah.
You need to allow your bond to mature in order for it to gain its maximum strength. And bonds take time to develop, whether you're gluing something onto a wall, if you're gluing 2 pieces of wood, or if you're gluing together a tooth. Just because you've shined a light on it doesn't mean that reaction has stopped. It will continue to go for, up to 24 hours. So now I need to make sure that I don't stress my adhesive by getting impatient and begin layering too soon. Because as soon as I start placing restorative material, as that material shrinks, it stresses the hybrid layer. This is the one area that I do not want any stress to accumulate. I don't want any stretching. I don't want any weakening at this interface, because that is where recurrent decay will occur. So I will wait a period of time. I'll go drink some Mountain Dew, go for a walk.
What was that number? We said like 5 minutes, it gets like 90 some odd percent.
5 minutes is right around 90%. If you waited 30 minutes, it would be around 95%. If you waited 2 weeks, you'd get to that 100%.
Yeah. So are you happy with 5 minutes? Can I be guilt-free?
And then I'll go ahead, like even in that 5 minutes, I'll place a thin layer of flowable. I just don't want to get thicker than 1.5 millimeters of restorative material in that first 5 minutes.
Yeah.
That my dad terms that the Alleman rule, where if you keep the volume of composite thin enough in that first 5 minutes, you are tricking the composite and shrinking towards the tooth. And so you're not stressing the hybrid layer by connecting hierarchies of bondability too soon. And so I'll do my resin coat. If I need to place a rib-on fiber, either due to high C factor, inner or outer caries that is left in the central stop zone, or a crack that's left in the central stop zone, then I'll place it there. And this will help alleviate some of the polymerization stress and also create what we call a fail-safe. So if we're going to try and design a failure, I want that to fail above the fiber that is being placed. I don't want it to ever fail at the adhesive interface.
So is that the indication for putting these, what's it called? The Ribabond or?
Yeah, Ribabond.
So is the indication of that so you've established a peripheral seal that's clean, no cracks, but over where the pulp would be, you've left some caries or there's a crack running over that area. So you put that, so that's like the stopping point.
And you could even put that on some very thin tooth structure if you were going to restore that all direct. It kind of, as the material polymerizes, as the composite polymerizes, what ends up happening is the fiber will kind of separate and disfigure rather than delaminate against a dentin wall or a dentin floor.
And you put this on once, so you've done your prime and bond, you've put a layer of flowable, you put the rubber bond and you put flowable over it again, or how do you like?
Typically I'll go back and I'll wet the Rib-On fiber before I've
in bond or
in regular bond.
Yeah.
So I'll do a layer of restorative composite, put that really thin, place my Rib-On fiber into that uncured composite, adapt that as well as I can, and then re-wet the fiber until it's well impregnated with also the resin. Now, Rib-On doesn't bond, but it rather just entangles. There's no double bonds to have a chemical interaction, but what ends up happening is it just slightly separates during polymerization, and it allows for the composite and the restorative material below the fiber to shrink towards the tooth, and the composite above to shrink in whatever way it wants to.
How often would you use this, like in a given week? Is this like a pretty common thing, or just?
Yeah, like if there's room to place Rib-On, if you have high C factor, a large structurally compromised tooth, there really isn't a wrong way to utilize the material. You just don't want the fiber out into the cabo surface. You always want it inside the peripheral seal zone or in that central stop zone. So if it's a very shallow prep, you wouldn't place it. You don't want it to get exposed to the oral environment. It will pick up water and will create a graying out of the restoration.
Are you using etch at all anymore, or are you just going like self-etching primers for the most part?
So I use etchant later on in the process. So I'll do my dentin replacement. So I'll continue layering. And then what I'll do is I'll re-prep my enamel lightly with a diamond burr and remove some of the adhesive that I've already placed.
Yeah.
And then once I've done that, then I will etch the enamel. If it slumps onto the composite, no big deal. Now there's a really important paper that not a lot of people understand. It's by Proenza, and it shows that if you're using a self-etch adhesive, if you get phosphoric acid etch onto dentin, you lose 50% of your bond strength with SE bond.
Yeah.
So instead of like 40 or 50, any dentin that's been contaminated is dropped down to 25 or 20.
Is there a way to reverse this if it happens, or you're kind of?
Well, go ahead and re-prep a little bit.
Okay. That's the only way.
But the best way to do it is to seal your dentin, do some of your dentin replacement, and then go back and then refresh some of your enamel margins, and then place your etchant. Because I don't care how good your hands are, like you're going to get like a little air bubble, and it's just going to go.
Yeah.
It's going to go everywhere.
Yeah.
And so, but if it's on the composite, it's no big deal. I just don't want to compromise my bond to dentin. And with self-etch adhesives, particularly SC Bond and SC Protect, you need the hydroxyapatite that's encrusting the collagen fibrils, because it'll form an ionic bond with the MDP molecule. And Fukugawa and Yoshida showed this in some research that was done in the last decade. And so if you remove those minerals, if you remove the calcium and the phosphates of the hydroxyapatite, then all of a sudden the MDP can't form that ionic connection. And now it's just relying mainly on a micromechanical. And with self-etch adhesives, that's not their strength. They utilize it, but they utilize both an ionic and a micromechanical adhesion and retention.
Okay. And so in a way, if you do it this way, in that 5-minute window, like you've done your like say like Optibond, like primer, bond, layer of flowable, less than 1.5 millimeter increment. You then have time to, reprep the enamel margins, put your like matrices and stuff in, etch, and that all kind of goes in that 5-minute window anyway. So it's not like you're sitting there idly doing nothing.
You can be productive in that 5 minutes and re-etching some of your, or reprepping some of your enamel margins, or if you like to place your matrix later in the process, that's a good use of time. It'll just benefit your adhesion and your connection.
Are you normally doing your dentine sealing portion of this with a matrix already in, or do you do it without?
I do it with the matrix in.
Okay. So you got the good, but then how do you, like, so when you're prepping the enamel margin again, you're not worried about like dinging your wedge or matrix?
No, I'm mainly just reprepping the occlusal portion. Maybe.
Okay. Oh, because you've sealed the floor off as well.
Yeah. I'm not going like deep in the preparation or deep in the proximal area.
Mm-hmm. Okay. Yeah.
Because like I said, I don't have the best hands. I
was gonna say that's impressive to to do that. Okay, so that's not too. One question I had that came up yesterday actually was, so you air dry. So if you're using just like Optibond as an example, because I know like if you're using like your favorite like Scotch bonds and you air dry the adhesive, right, to evaporate some of the solvent. But do you air dry the Optibond bond, or do you, once you've set it, you just air dry the primer, but you don't air dry the bond itself?
Yeah, the only time you need to air dry something is if there's solvent. If there's solvent, you need to remove either the worst solvent is acetone, a better solvent is ethanol, and another solvent that is commonly used is actually water. So anytime that you can remove the solvent, you will have better interaction when you place the hydrophobic layer of your adhesive. The way I view solvent in your adhesive, and everybody should be able to get this because everyone's got this app on their phone that's called Uber or Lyft. So, okay, you're in Melbourne and you are going to go out and you're going to go hang out with some friends, but they're like, parking is impossible. So what do? You call an Uber, right? Some Uber drivers are great conversationalists. Other ones, it's like, please don't talk to me. I've got my headphones in, like, just take me to my place. Now, how awkward would it be, no matter how good of an interaction you had with your Uber driver, if he's like, hey, is it cool if I hang out with you and your buddies?
Yeah, what are you doing tonight?
Yeah, like, what are you doing? They're like, well, we're gonna do this, and this, but how do you break it to them that they're not quite invited?
Yeah.
That's kind of what solvent is. Solvent is Uber drive, is the Uber. It's getting you to where it needs to go.
It's a mode of transport. Yeah.
But now you got to get rid of it.
Yeah.
So typically you pay them.
Yeah.
Then they take off. They go to their next ride, and you go hang out with your buddies. So what solvent does is it carries a difunctional hydrophilic monomer, such as HEMA or MDP, that will interact well with the intertubular dentin and the collagen and the hydroxyapatite that make up a material that is 50% inorganic, or only 50% inorganic.
Yeah.
Okay. So it's a very difficult surface. So you need that solvent to carry those hydrophilic monomers. And then once the solvent's gone, then you can place that hydrophobic layer of your adhesive after, and it interacts very well with the portion that is more hydrophobic on that.
Yeah, it didn't like it. I put the first time I wasn't sure, so I did it. I put some like air on the Optibond bond, and it's like so thick, so I just kind of started. It got like a weird texture to it, and it kind of just looked good at all. So
when you have like some pooling of the adhesive, because it doesn't have the solvent, what you do is just take a dry micro brush and you just wick away that excess.
Okay.
Now,
so that'd be the
problem with the adhesive that I use, SC Protect, and is that it's very radiolucent on the X-ray. So if you don't wick away like the pooling up against the band, because I put a band in initially, you'll have a radiolucency right in that area.
It looks like recurrent caries and stuff.
Be misinterpreted as recurrent decay or a gap or something like that. Optibond FL, I believe, is more radio opaque and is less likely to show up like that, but still the same thing. Don't introduce air into a completely hydrophobic adhesive. just wick it away. The only time you have to introduce air is when you're removing the Uber driver or the solvent.
Yeah. And what's your thoughts on some of these, I think it's like GC, like the genial flow and genial universal injectables and these kind of things. They work really well in my hands in terms of a material, but so like in terms of bulk, strength, I never, finish a restoration with those in terms of like the occlusal surface or anything like that. I'll put like proper composite, but I do a lot of like the dentine replacement like portion of it with that kind of stuff a lot. Do you have much experience with like just like flowables? Because they seem to be improving a lot compared to our traditional flowables that we would have had that are maybe a little bit more less radiopaque as well, or weren't filled as much, so didn't have the same strength.
So typically, even like there's been a lot of improvement in flowable composites, but I would say there's still a long way to go before I really start to, change protocols. So flowables, just speaking, in the whole family, is that they shrink too much and that they are too flexible. So their modulus of elasticity is lower than dentin in most cases, and they shrink about twice as much as most restorative composites. And if they shrink twice as much as most restorative composites,
that's a lot.
Too much, because if you bulk fill a restorative composite, you're going to lose 50% of your bond strength right off the bat. So with flowable, you're going to have some of those same issues. Now, if you keep a flowable or an injectable incredibly thin, less than a millimeter, remember, composites are stupid. Like they'll go where the physics and tells it to go.
Yeah.
If you trick it to think it's so thin that it can only shrink in one direction, it doesn't matter if you're in a high C factor preparation, because those two walls aren't connected. So I would use those materials as just simply as a resin coat, and then I would layer with a restorative composite that mimics the modulus similar to that of intermediate dentin. And the best composites and older composites called APX from Cuare. Voco also makes a very nice dentin replacement. But as far as like the GC composites, I haven't used them as much. Actually, I've never used them, but there are some aesthetic composites that I'd like to use for like some enamel replacements, like they're just,
Do you heat your composites, or?
I only really heat my composite for cementation.
Okay.
So anytime that you increase or add heat, you're adding more energy into the system. So the molecules are shaking and they're moving to a lot faster. And so as soon as you have that added energy, then the stress as it's being polymerized can actually be a little bit more than I'm comfortable with. But if you keep it thin enough, it's probably no big deal. But most people that are trying to like heat composites, they're trying to get it so it's less viscous so they can put a larger increment faster.
Yeah.
If there's one thing that I do, it's like I don't talk fast.
Yeah.
And I don't do dentistry fast.
Matches the rhythm. It's a personality thing. What about the delivery of composite? Are you do you like deliver like it's like on a delivery and you just like pick it up with like an instrument and bring it to the tooth, or do you have the injectable kind of and then you shape it?
So I've got the gun.
Yeah.
And I just like cut little balls, like little 2 millimeter balls, and then I put them in the restoration, and then I pack them so they become thin 1 millimeter increments.
I think I'm too reliant on flowables, I think, because I don't use like composites as much, or I've used like warmed or heated composites a bit. It doesn't handle well in my hands. Like I don't feel comfortable if I've like prepped, like especially like one like a more of like a slot prep, like a smaller MO or a DO. To like, am I getting this down enough? Is it actually going to be sitting properly where it needs to go? That's like my sort of worry, where I find flowable just in my head makes more sense, because it'll sort of like sit there nicer and be more adaptable. And just like a little perio probe just to make sure there's no air bubbles and things. And
so to answer that, so do that with your resin coating. That technique is great. And then for these little difficult areas to adapt, do just a little dot of flowable, and then take a thin increment of composite, and something that's not a very stiff composite is better.
Yeah.
And then you push it into that small.
So the flowable kind of
So
it's called
a snowplow technique. You're from Canada. You live in Australia. You know what a snowplow is.
Yeah.
Uh,
They'll get it.
But and then compact it with like a medium micro brush. It doesn't have a lot of tug back.
Yeah. No, it's good. It's good to just have you on and pick your brain on these things, because it's like stuff you just do it every day and you're like, don't put much. I mean, most people, I know the biomimetic dentists obviously think about this stuff a lot, but the average dentist is not thinking about this stuff too much. But I think, on the spectrum of, doing biomimetic dentistry to just doing like shoddy dentistry, I like to be sort of at least one standard deviation above the mean. So I'm trying to get to that point on a predictable level.
Perfect.
So yeah.
We can get you there, Omid. No problem.
So I got my rubber dam. Sometimes I use Scotch Bond still if it's there. And I always think of you when I do, but at least I'm like trying to do my best with what we've got time wise and material wise and things like that.
You want to know how to make Scotch Bond work really well?
Yeah.
Bart Vanderbeek showed that if you use Scotch Bond Universal as your priming step and you air dry it, and then on top of that, you put the adhesive. So the second bottle of SE Bond 2.
Yeah.
Then you got bond strength similar to SE Bond.
Okay. Nice.
So you just need a very hydrophobic addition to your adhesive.
So you put your Scotch Bond, don't cure it, just air dry it. And then you put the SE
You're literally using Scotch Bond Universal as your bottle one. And then anyway, it's still a compromise, but it's the only way that you can.
I wonder like, I'm not like, sponsored by any of these companies or anything, but like as a financial way, is it cheaper to do it that way versus buying the SE Protect? Like
that I wouldn't know, but it's probably about the same.
Yeah. So it wouldn't be much perks anyways, but no, I'm as an associate anyways, like I'm not too fussed about the cost of the materials. So it's just like, if you can get it, you can get it, and if you can use it, then. But the Optibond, I do like how viscous it is, and then just like it looks more substantial than what you would use otherwise with like a Scotch.
Yeah, that's what FL stands for. It stands for filled.
Yeah,
that's what FL and Optibond FL. It's not fluoride, but rather the filler content that they put in it.
Yeah. Okay, let's talk about a little bit about early diagnosis of cracks, and more so I'm just curious because obviously you do deal with this stuff a lot in terms of what you communicate to your patient because some of the tug back or resistance you get from a patient, you go for a hygiene visit and they've got all these like old amalgams that have been there 20, 30 years, asymptomatic, not giving them any grief. You're a new dentist, you walk in and be like, you have cracks on all your teeth and we gotta do something about it. We gotta replace the restorations or we gotta go on to an indirect. So one is, can you tell me a little bit about how you communicate the importance or what needs to be done with the patient? And then in terms of treatment, so if it's like a occlusal amalgam, you talked about earlier about how much the strength force or the force needed to cause cracks reduces with these big, occlusal restorations and the depth of them. But do we, as a baseline, if we see a crack, replace the restoration with composite, so this is more adhesive versus like wedging, or do we take it out and just go onlay or cuspal coverage every time? Tell me a little bit about that workflow or mindset a little bit.
So the first thing that I'll do is I'll ask the patient if I see a peripheral rim fracture, where a fracture is, on the edge, and it's usually associated with the isthmus that's greater than 2 millimeters. Mm-hmm. You really don't know if that crack is passed into the dentin or if it's stopped at the DEJ. Mm-hmm. That's what the DEJ does. It literally redirects forces and it acts as a natural crack stopper. Mm-hmm. So if you see a crack into a marginal ridge, it's a red flag. Mm-hmm. There's a chance that this tooth is at risk of fracture. So the next thing I'll do is I'll assess the isthmus width, the cusp thickness, maybe a box depth. And I'll ask the patient, Miss Jones, you've got a large restoration here. The restoration's holding up okay, but what I'm seeing is some accelerated fatigue of your tooth. Have you ever had any teeth that you've had some intermittent pain on biting? And oftentimes they'll say, occasionally when I bite on like an almond or something like that. And then you can, go into the conversation of, you've got a crack that is undermining the filling. And as that crack is moving, this is what's elucidating the pain. This is what the hydrodynamic theory of pain, you don't have to talk about that, but you got a crack. And when the crack moves, that's when when the crack isn't moving or the crack is mineralizing on the pulpal side, then that's when you forget about it. Mm-hmm. Now, some of the patients you'll see, they'll say, I don't remember any of it. Mm-hmm. And oftentimes it's a guy. It's like, they don't care about their teeth. They try and block out, any kind of pain. I've got a high tolerance for pain. Yeah. But you still talk to them in terms of this tooth is at risk of fracture. The sooner we treat a fracture, usually the more conservative we can be. Now, we don't know until we open this up. I want to, at least prepare you for, worst case scenario. We're looking at more of an indirect approach, but we'll still be able to preserve the areas of tooth structure that aren't undermined by cracks or decay. Mm-hmm. If the patient is proactive, or maybe they've had a tooth go to root canal, or maybe a tooth being lost from fracture, oftentimes they'll be like, I'm so glad you mentioned this. Yeah. I've had a really good month of work, or, I just don't want to think about, my teeth in the next decade. Let's actually fix this. Mm-hmm. And, in those situations, you prepare for the worst. You figure out, what your prep design is going to be if you're going indirect, and that will help facilitate your crack dissection, which is a very difficult concept to master and very uncomfortable for most dentists. But if you can, get the patient to understand the severity of cracks. Yeah. I mean, most patients really understand the idea of a cavity. Yeah. It's like, oh, I've got a cavity. Oh, let's get this fixed. Mm-hmm. You say you got a crack and it's not symptomatic. Mm-hmm. Oftentimes they'll just be like, okay. So sometimes I'll take a picture. I'll show them the cracks, and sometimes they'll bite, sometimes they won't. The main thing is I don't want to ever push treatment on it, but I want to give them the best information. I always like to tell the patient, look, you're the driver in this bus. You can determine how fast and how quickly we get to the end goal. And only you know the goal. I'm just the bus. Mm-hmm. I'm here to facilitate your goals and your needs. This is the best information that I have based off of the radiographs, based off of the intraoral findings. How would you like to proceed?
Mm-hmm. Yeah, that's the best way. So you notice the crack, they're happy to go ahead with treatment. So you're saying most of the time you'll say, I won't know whether we can go direct or indirect until we actually get in there, remove the restoration, and assess the tooth. Is that sort of how the conversation goes?
Exactly. Yesterday, I fixed the tooth. There was a large MOD composite, part of it had chipped away. And 6 months ago, I think I told the patient, we might be able to just redo the filling. Mm-hmm. And as soon as I opened it up, the composite was totally unbonded. Yeah. So it was moving 170 microns every time he was chewing. And there's this huge oblique fracture undermining the tension cusps. Mm-hmm. And the first thing I tell my assistant, let's grab the camera, let's videotape this, let's record this through the microscope, because dentists are seeing this all the time and they don't know what to do. Mm-hmm. So we literally recorded this yesterday. We onlaid the cusp. We onlaid the cusp not for a compression dome or anything like that. I onlaid the cusp so I could visualize the crack. Mm-hmm. If I try and chase a crack and undermine a cusp, the chances are I will leave a portion of it because I won't be able to see it. Yeah. If you can't see it, you can't treat it. Mm-hmm. So our recommendation is, if you have deep decay, deep cracks, the most important thing is visualization. So increase your magnification and onlay cusps so you can get that solid foundation that will be the foundation for your biomimetic restoration. If you have a sandy or a weak foundation, it doesn't matter how pretty the top is, that tooth and that restoration won't bend and flex like a natural tooth. So I onlaid the cusps. I identified where the DEJ was and then where the crack was originating. And I started moving my dissection away from the pulpal side. So I was moving towards the external surface and cleaning that peripheral seal zone so it became crack free. And what ends up happening is you'll think you're at the bottom of the crack, and then you'll dehydrate the tooth, and the dentin on top of the crack will become more opaque. And that's because it's less hydrated. As soon as you have a crack, the pulpal fluid can't hydrate and give the toughness on that occlusal side of those oblique or horizontal fractures. So air dry this will help visualize the crack again, and then continue with the dissection until after you've dehydrated it, you no longer see this milky or more opaque side of the dentin. Now, vertical cracks are different. Vertical cracks, what ends up happening is you have the exact same amount of hydration on both sides. The pulp is hydrating the lingual and also the buccal side equally.
Yeah.
So it's a little harder to visualize the crack because literally you're only looking at the crack. When you dehydrate it, it's, one side isn't becoming more and more apparent as the delaminated dentin structure. So you really need to have high magnification for vertical cracks, because oblique and horizontal cracks, they're the easy ones to take out. And even if you left oblique and horizontal cracks, it's not the end of the world. Like the worst thing that's going to happen is that patient's going to lose a cusp. The tooth is still restorable.
Yeah.
But I want you to get so good at oblique and horizontal fractures, because when you have the vertical cracks, you know what to do, you know how to excavate, and you have the confidence to go down 7, 8, 9 millimeters without exposing the nerve. And there's no better feeling than taking out a vertical crack, because the vertical cracks are the cracks that cause teeth to lose vitality. And in worst case scenarios, they have to be extracted.
Yeah.
And when you're a bad exodontist like myself, if you're bad at taking out teeth, the last thing you want to do is say, give me a 301. It's like, no, let's treat this crack out. Let's take this vertical crack out early. If you just try and bond over a crack, the crack still has a potential to propagate.
Yeah.
You just put rib-on fiber over a crack and try and bridge two sides of the crack. That crack still has the potential to propagate. If you've drilled to the bottom of the crack, you can now connect the two sides cohesively. You can connect them with your adhesive procedures. And this is what engineers do. Because when engineers ignore cracks, whether it be in bridges or airplanes, guess what? People die.
Yeah.
If dentists ignore cracks, people
dies.
lose a tooth.
Yeah.
Or the tooth dies. It's not the end of the world.
Yeah.
But the patient might be like, why didn't you say something 5 years ago?
Yeah. That's the thing. So Carrie's crack excavation, when do you call it quits, especially on the vertical? Like how deep are you going to...
On the vertical?
Like, are you going to go subgingival? Like,
yeah, I'll go subgingival. I'll try and keep a shell of enamel or root, so I don't perf out the side. I got to make sure that I can re-isolate.
Yeah.
If it's really, really deep, maybe it's a good idea to pre-band before you get to the bottom of your crack. But trust me, like, I don't care how long you've been taking out cracks, you just don't know how long they're going to go. Sometimes it's like 2 millimeters. Great.
Some goes down the whole root. Like, you don't know.
Some of them go down the whole root.
Yeah.
But if you go 8 millimeters down and that tooth ends up being lost, guess what? You have a much better idea that was already mid-root. Because you went 8 millimeters down, and guess what? The crack still looked dark. It still looked like an old crack.
Yeah.
A fresh crack looks very light. It's very faint. An old crack has picked up pigment and is very easy to see. And if you're 8 millimeters, 9 millimeters down, and that crack is not becoming more and more less apparent, then, if in 6 months after your best effort, the patient comes back with the J lesion and you have to take out the tooth, and sure enough, that thing was all the way down the root. Guess what? You did the best you can.
Yeah.
Now, if you just stopped at 2 millimeters and it was like 8 millimeters,
and you could have got rid of it.
You could have gotten rid of it. You just don't know. And so you have that second guessing.
Yeah.
And one of the people that we trained this last year, before he took the mastership, he had a case where he did a crack dissection and he did the best he could. But unfortunately, the tooth ended up being lost. And he was looking back on it and he's like, I went 3 millimeters. I felt like I did good. I put all these different layers and, made this nice restoration on top. But it wasn't the filling, there wasn't the restoration that failed. It was that crack. And maybe I could have gotten to the bottom of it 6 months ago.
Yeah.
But I stopped early. So if you go 8 millimeters, I'm not going to say keep going further.
Yeah.
That becomes very, very challenging in terms of visualization, isolation, other problems. But if you go 8 millimeters and I see a very good, strong effort, at the very least, you've reduced the lever arm on that fracture. It'll take more energy for that crack to propagate.
Yeah.
What I hate seeing is people just, taking the easy way out and trying to bond over a crack and say that the adhesive infiltrated underneath that crack. I mean, a crack into dentin is a gap. If I'm super adamant that I don't have a gap underneath the class 2 composite to the point where after I place my adhesive, I'll go wait 5 minutes. I'll literally leave the other room so I don't rush the procedure. Why am I not that adamant in terms of crack dissection? Because a crack into dentin is not biomimetic. It's unbonded dentin to itself or weakened dentin to itself. And so if I can reconnect that by disconnecting it first and then reconnecting it with an adhesive approach, it's a game changer.
Yeah. No, it's an interesting thing, cracks. You see a lot of it. And I think it takes a little bit of visualization as well to understand, because how do you know if it's not propagated to like the pulpal floor and stuff too, right? Like unless unless they're asymptomatic and then you start endo and then you're like, oh, the crack is here. Okay, we can't do much now. Like, sorry, like prognosis is not good. But so at least, so you're saying as a starting point, again, my goal, to be the 1 SD, 2 SD above the mean. You're prepping these teeth, you remove at least the peripheral. So you want to make sure the DEJ is crack free within reason of 7-8 mils.
If you can get that crack free, any crack that's in that central stop zone, 3 millimeters, 5 millimeters from the occlusal, 3 millimeters from the adjacent, 5 millimeters from the occlusal, all of a sudden you get the compression. You get the compression dome that is stabilizing that area that is disconnected or weakened. And, you can place some fiber over that. You can redirect some of the forces. But if you've disconnected around the perimeter, it's going to be much more stable.
Yeah.
Remember a tooth, it's not solid tooth structure. There is a hollow chamber that's filled with the nerve. But that hollowness doesn't weaken the tooth structure because you have that nice compression dome. It's able to withstand all those forces. It's the same thing. If you can have a very clean peripheral seal zone free of caries, and you can have a high bond strength, and you have a peripheral seal zone that's free of cracks, then any areas that are where the bond is compromised, either from leaving inner or outer caries near the pulp or a crack, those areas can be supported by the strong perimeter.
Yeah. That's good. I mean, there's a lot to it. I think it's like with anything in dentistry, when you go down the rabbit hole, you realize how deep and broad it is. Because on a superficial level, you're like, okay, yeah, just edge prime bond, like get the restoration in as you get taught in dental school. But then you go into it and you're learning about the C factor. It's like, oh, okay, what's that? Or the thickness of the cusp and tooth assessment, and then there's cracks and intricacy of bonding, like the technique sensitivity of like proper bonding. Like dentistry is becoming like harder in a lot of ways, right? Compared to what it was like in the 70s or something. We would have just, everything was amalgam, everything was PFM crowns, and
Yeah,
way
as soon
harder
as you
now.
know what you're up against,
Yeah.
then all of a sudden you realize maybe I don't want to open up that can of worms.
Yeah.
There's a reason why I don't do my own endo.
Yeah.
Like there's a reason why I don't do surgery. Because I know the complications that I can screw up with just a class 2 composite, which everybody thinks that they're really good at. And it's like, I don't want to have the complications of, routinely missing an MB2 or instrumenting to the point where I'm like, getting ledges and causing vertical root fractures from my root canals, or, problems with graftings that aren't, taking. I mean, when everything works great, dentistry is fun.
Yeah.
When you have those complications, it's like, and you don't really know how to fix it.
Yeah. I
mean, in the words of George McFly, I just don't think I can take that kind of rejection.
It's a really interesting debate. Like, going through like the oral surgery residency and stuff too. Like you see the depth of knowledge and experience that this like the Max Fax guys have going through and stuff too. And it's like you look at it, dentistry, like, do I do any, like, should everything just be done by specialists, or should generalists be doing most things? It's a hard balance to appreciate that. Like you said, like, do I know enough to do good endo? Do I know enough to do, good aesthetic dentistry or good like gum grafting procedures or ortho or all these things? And then there's dentists that just do everything and they do it quite well. So I think my rationale, my philosophy, like I go by like the 80-20 rule. Like I think the specialists are there to handle those 20% of cases that are tricky, because like a lot of stuff you should be able to, like within the reasonable skill training, you should be able to handle and manage. Taking out wisdom teeth, for example, like there's going to be the 20% of cases where you're not going to just touch it, and that's why they're there for. So you can send them off to the specialist and they can deal with that and deal with the complications that might arise from that. Same with endo. You can just stick to your centrals and premolars and things, and then refer off the molars and stuff that you're not comfortable with. So I think it's good to know your own boundaries, I guess, like you said, and see if you can deliver good treatment, and the treatment that you do deliver, can you manage the complications from there? Because I think that's like the key. Like if you can't manage complication, then you shouldn't maybe do it at the start. Yeah,
like you spent a year to get better at implants and surgery. Like that was a sacrifice.
Yeah,
that took money out of your pocket, in the short term, but it's also going to pay dividends, where you're going to have a level of confidence that I'm never going to attain because I'm not willing to sacrifice that. But like, no one can take that away from you. And I'm so glad that there are people in other specialties that have, done the 10,000 hours and have, worked through the complications, that I can just say, look, what I'm good at, I'm really good at. What I'm bad at, I'm okay. And I'm comfortable saying there are better people.
Yeah.
And as long as you can like be comfortable with how far you can hit a golf ball, then you can realize this is what I have to do to beat the people that hit it further than me.
Yeah.
I mean, when I'm at a skate park and I'm like the old 36-year-old weirdo, it's like, I'm
with
not
the wrist guards, protect the money makers.
Yeah. But it's like, I'm having fun because I'm comfortable that I'm not competing with the 17-year-old that is, so far advanced compared to me.
Yeah, no, that's I think that's the beauty of dentistry is it is a skill, right? So you can always get better. You can always set some benchmarks for yourself and try and improve. And we're lucky to have, with the internet and access to Zoom and courses and experts from around the world and everything like that, that we can access like people who are experts and like learn from them and see it. So I think that's an awesome place. So I think right now in dentistry, while like dentistry itself might be harder clinically than what it was maybe 30 years ago, 40 years ago, the standard of dentistry is getting much better because everyone can kind of see what the playing field is like.
Exactly. It's like, yeah, maybe it was simpler in 30, 40 years ago. But I'll tell you what, before biomimetic dentistry, my dad hated dentistry.
Yeah.
I remember that as a kid. I'd ask him, how was the day? He's like, oh, I did a bridge, I did a crown, I did a couple of fillings. I don't want to talk about it. Let's go hit golf ball. I was like, and then all of a sudden he talks to my 7th grade class 2 years later.
Mm-hmm.
He's excited about dentistry.
Yeah.
And this was just like when adhesive dentistry was kind of emerging.
Yeah.
It wasn't nearly as like complex as what we just talked about in this hour. And so even though it's more complex, the predictability has increased as people have become specialized in certain problems that dentists and patients were facing on a daily basis.
Yeah. That's amazing.
So cool.
That's so cool. I think that's awesome. And I think everyone appreciates what you guys are doing with biomimetics. And because, we shouldn't take restorative dentistry as like basic dentistry. I think that's like a misconception that like a lot of dentists have. It's like, and as you get more experience, some dentists want to like, their career goal is to like get beyond drill and fill dentistry and stuff like I'll only do more advanced procedures and things. But I think a lot of people should put more weight and appreciation behind what restorative dentistry is, because it is bread and butter, but it's not done well by majority.
I mean, it's what gets me excited. Like a large MOD, a large like MO, deep caries, deep cracks. That stuff is like what gets me like pumped.
Yeah. No, that's great. I try to, I don't not like it. I just, it's finicky. And I think I get frustrated because you like, when you don't, like you said, like when you're learning a new skill, when you don't have, like, you can't execute where your brain wants you to execute, like your hands aren't there yet. That's when like that frustration creeps in. I'm sort of in that stage of it now. But
that's part of the learning process. I went through it. Everybody goes through it.
Yeah.
Like, remember like when you're frustrated with something, the anger is the secret sauce.
Yeah.
Being a little angry that you weren't as good as you thought you should be. That's what drives you.
Yeah. I think that it's important to be self-critical as well if you want to get better. Davey, man, I really appreciate it. This has been an awesome, we're in 2021 now. The first one was made 3.5 years ago. So it's really cool. And I think one thing that I'm proud of, just doing these projects, I mean, the podcast is just like a fun thing that I've just been doing. But when you do something for long enough to be able to have these moments where you can like chat to someone where you've had them on before, years before, to see how far you've come with your career and how far some of the other guests have come. It's just been an amazing sort of journey to be part of the dental community in a way and try and contribute.
I can't tell you enough, like how many people got introduced to like biomimetic dentistry or the mastership program from that interview where I was like sick as a dog.
Yeah.
And like trying to, get through it with Sudafed, Dayquil, and a lot of caffeine, a lot of mountain. And it wasn't as crisp as what we just recorded today.
Yeah. But it did the job.
It's super effective. It got people interested. It made them more excited about, routine dentistry that was just kind of just grinding them down to the point of, serious frustration or disillusionment.
Mm-hmm.
And so like what you're doing, Omid, is so important because, there are young dentists that want to be great.
Yeah.
You're giving them exposures to people that, have a little bit more experience or may have been going through the same frustrations as they're currently going through. And their experiences, at least to them, are really significant. We might look at it as like, oh, in 2 more years, you'll feel really good about how to matrix something that's very hard to matrix.
Yeah.
When you're going through that learning stage, it's so hard. So many dentists come home and they're just dejected and frustrated. And you provide hope, or at least give them a vision on like how to proceed to get better.
Yeah.
And so be very proud of what you've created.
No, I appreciate it, man.
I love seeing your success, and I feel very honored to be a part of your growth.
Thanks. It's been a shared history. Like I said, I think this one will be another one of the episodes that gets into the top 10. And I think hopefully we'll get to meet up in person again once we get out of this mess that Australia is in and have a few beers and catch up. And I look forward to it.
All right. Take care, Omen. Thank you so much.
Thank you for tuning in for another episode of the Noobie Dentist podcast. Please be sure to subscribe and head over to iTunes and give the show a 5-star rating. For all show notes and to access all previous episodes, head over to www.noobiedentist.com. Have a great day.